Well, hello, everybody. This is Greg Polin. I am the Mary Lowell Leary Professor of Medicine and Infectious Diseases and Director of the Vaccine Research Group at Mayo Clinic. You're listening to COVID-19 Vaccines, an Evolving Landscape. This is the fifth of a six-part series on COVID-19 vaccines, and today we're privileged to have with us Dr. William Curry. He's Professor of Medicine at the University of Alabama at Birmingham. Bill has had a lot of experience with working in health equity, and we're going to use that expertise in talking about our topic today, which is reaching rural locales with COVID-19 vaccine. Well, Bill, welcome.
Thank you, Greg. It's great to be with you.
Well, let me kind of get us introduced to the topic here. We have seen that the rate of uptake of COVID-19 vaccines has slowed down nationally, in fact, by about half. And in particular, we're recognizing the need for a targeted approach for specific populations. This is happening even though vaccines are free, they're readily available for most, but we'll come back to that. But some populations still have logistical, socioeconomic, and even cultural barriers that either prevent them from getting the vaccine or that kind of in combination cause them to choose not to get vaccinated. So we're really going to be focusing today on rural populations and how we might target our approach to improve access and communication around COVID-19 vaccines. So Bill, let me just start off by maybe a basic first question. How do we define rural populations? And for you, is that term too general? Should we be more specific?
Well, I think we do have to be specific because just if you said, tell me about urban populations, obviously you'd have to say, well, there are subcultures and subpopulations within all of those. So the same is true of rural America. There are 57 million people who are classified as rural. There are a lot of different classifications, and we could argue about those numbers, but it's a sizable number of people. And in some states like Alabama, it's roughly 25% of the population. The important thing, at the risk of generalizing too much, is to say that there are categories that we could propose. For example, if there's some places that maybe had been a farming community that now have become part of the exurban metropolitan development that's creeping around them, out of Atlanta or out of Birmingham or wherever it may be. Then there are places that still are far enough out. They're farmland, they're contained, it's a farming community, it's cohesive, and it may be fairly prosperous. A lot of those, if they're ongoing, they tend to be fairly prosperous. And you'll find a lot of that in the upper Midwest, for example, or in our frontier states out west. And then there is the prosperous rural area that maybe is far enough away from the metropolitan area that it's a transport hub, an economic hub. There are a lot of local businesses. It may be a health hub, maybe a small regional referral area for 4 or 5 counties for healthcare generally. And then you get further out in terms of distance, but also in terms of further down the scale in terms of socioeconomics to something more like a rural extraction economy. An example would be timber or mining, or in our part of the country, the chicken industry, where something is just grown and then put in a truck and taken away, or put on the river and floated away down to the port. And there's really no value added. And so the jobs are lower paying and it doesn't support as much of an economy. And then finally, you could say as a final archetype, there's the rural isolated, which will overlap some with the extraction economy. But examples would be parts of the Mississippi Delta where people are living out of the welfare stream. They live from Social Security, much older population, poorer population, economically marginalized. And so that's a very different situation for healthcare and for vaccines or whatever it is you want to talk about.
So Bill, yeah, maybe briefly describe what healthcare is like in those different rural settings.
Right. Well, the ones that are prosperous tend to have a cohesive community and a well-structured and supported healthcare system. And that usually means there has to be some tax subsidy in order to cover uninsured and underinsured people, and to make up for what operations is not going to make. I mean, the average hospital has a 2% profit margin pre-COVID, and rural hospitals are worse than that. Theirs are slightly negative. So you have to make that up with tax revenue. And if you have a poor economy, you can't do as much of that. There's not as much tax revenue to do that. So the more prosperous communities tend to multiply that value through the healthcare system. But then there are other sorts of challenges that have to do with the culture. There's still obviously a good deal of folk remedy that's out there. There is sort of blended naturopathic and folk remedy, and deciding when your aunt is going to say it's time to go to the doctor. But then there's also just the problem of access, with the scarcity of services, not enough doctors, not enough APPs, rural hospitals being poorly funded sometimes, and even closing. We've had quite a few rural hospitals to close pre and during COVID around the country. The physicians there tend to be fewer physicians and maybe not as adequately trained. The transportation issues, even when you're not in a distant pioneer or a frontier kind of state, that people may not have an automobile available, maybe one in the family, and it's used for work. And then, the whole thing about COVID was we were going to do all this with digital care. And that's worked great right here around the metro area, or in suburban areas where there's good broadband. But there's still plenty of swaths of rural America with poor broadband access. So it's sort of a double whammy. Okay, well, we want to do this care, improve rural healthcare with telehealth. It's a great idea. It's not the single solution, but it's important. But without broadband, there's no way to do it.
So given all that, Bill, describe for us how COVID-19 has impacted rural populations.
Sure. So, I think most people who know anything about rural populations know that we have a lot of disparities in health outcomes. And that has to do with sometimes with these distance and economic challenges. We're talking about what we call the social determinants of health, transportation, and all of those kinds of things, access, insurance, poverty, all of those things. And so for diabetes, for heart disease, for various kinds of cancer, there have been big disparities for a long time. Well, what COVID did was just to amplify that. So it's the same pattern, that there are more people with uncontrolled diabetes and complications of it. And because that's a risk factor for bad outcomes for COVID, then you see worse outcomes for COVID within those populations, with obesity, type 2 diabetes, related heart disease, and so forth. Smoking is higher in a lot of our rural populations, and again, the COPD, a bigger risk for COVID. And then you take the challenges to the healthcare facilities and lay that population of people into that community, and they're not going to be able to cope as well with COVID. And so we've had mortality rates in rural communities that were significantly higher than they have been in some of the headliner metropolitan communities around the country. So, but because the numbers are small, it doesn't get the headline.
Yeah, and you can really see, as you describe, the multiplicative effect of all of these longstanding, and in many ways kind of structural issues that exist. So let's sort of transfer now into talking about the status of vaccination against COVID-19 in rural locales.
Well, again, that's heterogeneous too. You'll find rural communities overall have a lower vaccination rate, around the country. The rural rates are maybe around 50% if things are going pretty well, but we have a number of rural counties in our state where it's more like 24, 25% vaccination rates. And at the same time, you'll find examples where it's much higher. And even some of our highest counties in Alabama are small, isolated rural counties. there's always a story about that. There is a physician, there is a health officer, there is a pastor,
A
there is
champion.
somebody. Yeah, there's somebody who has said, we can do this, we can do it better. Don't listen to all this made up stuff, or don't listen to your fears, listen to the facts. And I'm rolling my sleeve up and I'm being an example for you. So somebody has done that. It might be a sheriff or a public office holder, but very often it involves a church.
Yeah.
At least in rural America, that's the most trusted institution. And so getting advice through the church or examples through the church, or even having a vaccine event at a church is a way to get that ball rolling. Overall, though, there have been a variety of reasons, everything from all the social determinants and the structural problems that you'll find vaccine rates are lower, especially in the rural Southeast and around Texas, and up into the lower Midwest. The upper Midwest, perhaps a little better in some of the best states. And then in the frontier states, again, more like the rural Southeast. So,
Yeah.
it's varied around the country.
So we've certainly seen in terms of the vaccine rollout that there have been, let's call them different challenges for the rural population compared with urban populations. Can you provide some insight into that?
Yeah, if you look at what was the strategy for having, for providing vaccines, it was a combination of mass events where you could do 1,000 or 2,000 vaccinations in a day, plus maybe trying to have access through pharmacies. Well, just in terms of the structural side of that, there are not good locations for mass events because of the transportation issues sometimes in a rural community. There may not be a pharmacy. There may be a pharmacy desert. You may have a rural county that has only 2 or 3 pharmacies for an entire county of 25,000 people or so, and they're scattered. So they're, again, to the transportation problem. So all these that people thought, well, this will take care of it. There was a problem there with supply. But then there's I think the bigger problem is people's mistrust, their skepticism, their concerns about safety, the misinformation that they've heard, and then health literacy being a problem. The other thing I would mention is I'm here in Alabama where the Tuskegee syphilis study happened, and there's still a legacy of that concern about whether we can trust the healthcare system. For the Hispanic population, there's concern about INS and about being in a database.
Yeah, really well articulated set of challenges, Bill. So as I listen to it, to me, it seems like there are sort of 2 general areas of improvement. The first is access issues, and the second, maybe we could call communication and education. What are the tactics for making it easier for those who want to get vaccinated? And as we talk about this, what does this mean for immunization programs going forward, where we've faced these challenges with virtually every aspect of healthcare delivery?
Yeah, I think you've got to make this available. You've got to go to where people are, whether it's work or church, someplace that they trust. And then we've got to increase the engagement in the community. There's got to be a better education, community health workers, community leaders, pastors, church leaders, all of those folks, in addition to public health and private physicians and APPs, who encourage people continually. This is going to be a problem ongoing. This is not one and done. So we'll still be trying to get people to get vaccinated from here on. And so we need to just have a consistent, trusting message. When the EUA goes away, that will help some people, but then we have to just counter the concerns that people have with facts, and more importantly, with examples. If their friend gets vaccinated, their family member gets vaccinated, they're much more likely to come along.
Yeah, the misinformation and disinformation has really been hard for all of us. What about on the communication and education side?
Well, we've had some success with community health workers because they tend to understand the culture of the community and be known in the community, that's an additional asset. that can be added, and our public health department has been open and helped to fund that. But I think just keeping examples of people who are saying this is still important, whether it's a celebrity or just a friend, through media, through social media. There are a lot of the cultures, like with the Hispanic culture, where social media is very important. And so working with the Hispanic radio station, but also with Hispanic social media, that helps to overcome some of those barriers. And then the misinformation is just a matter of saying, look, this is not politics. This really is about what's safe, just like any vaccination or any healthcare move is. This is not a political decision.
Good. Well said. Well said. Well, Bill, I really want to thank you. You've been very erudite and I think thorough in giving us a deeper look into the challenges that you face when you're dealing with rural populations. As you have mentioned, COVID-19 vaccination in the US is certainly not a one and done or a one size fits all situation. It's clear we need a tailored approach for those populations that are not taking up COVID vaccines at the rate we'd like to protect them with. And this really starts with identifying and understanding, as you have, the who, where, and why, if you will. I think the last point is, and you articulated this very well, Bill, this is an ongoing problem. In other words, we have this vaccine disparity regardless of which vaccine we look at. So one of the hopes I think we all have is that by recognizing, funding, and overcoming some of these barriers that you've described for COVID vaccine, we'll have a very positive follow-on effect, not just for other vaccines, but for all of healthcare delivery. So I hope we'll see that come to pass. I believe that we will. We have the focus, we have the resources, and we've got experts like yourself who are on this topic and helping us to understand it. So Bill, thank you again very much for being with us today.
My pleasure. Thank you, Greg.